Hello, my name is Scott Butsch, and I'm the Director of Obesity Medicine at the Bariatric and Metabolic Institute at the Cleveland Clinic. I'm going to talk today about the medical management of weight regain. Here are my disclosures for Rhythm Pharmaceuticals, in which I am an advisory board member as well as a consultant. Objectives of this talk are to understand the great variation in response to bariatric and metabolic surgery, to differentiate primary surgical failure, which is also called inadequate weight loss, with secondary surgical failure, which is also known as weight regain. Understanding the medical treatment options for both primary and secondary surgical failure include a combination multimodal therapy where anti-obesity medications may be indicated. Lastly, to differentiate the anti-obesity medications and identify specific indications to individualize pharmacotherapy in the post-bariatric and metabolic surgical patient. It's important first to understand a person's response after surgery, and this may help tailor the treatment option. Certainly we know and see patients who don't do well or regain their weight, and I think it's important to understand what the nadir weight is. By understanding their nadir weight, we can classify them as someone who responded well to surgery and has regained their weight versus the individual who never responded at all or who had inadequate weight loss after surgery. We do know that there's a great variation of response to bariatric surgery, as you see here in both gastric bypass and sleeve, with some part of the people who undergo surgery just don't respond. And this inadequate or suboptimal weight loss response is likely biologically driven and therefore may entertain a different treatment strategy versus those individuals who regain their weight. In fact, I think combination therapy with anti-obesity medications would be a great strategy for these individuals who do not respond well. As you see here in someone who had gastric bypass, responded but needed topiramate to really bring their weight down. Secondly, there's individuals who respond well but still have severe obesity. Again, this is a suboptimal response. An individual here, I put her on topiramate and she responded very well, losing about 100 pounds in 1 year on topiramate. So these combinations may be perfect for individuals who do not respond well. On the other hand, those people who regain weight, the etiology is likely multifactorial. Therefore, obtaining specific weight history may help identify contributing factors. Certainly, not everybody has a graph like this. Maybe individuals maintain that weight for a long period of time before some event triggers their gain, or individuals who have an early event and then come to you after a period of weight stability. But we do know that the treatment is not simply just eat less and put them on a restrictive caloric diet. And we're not going to speak about that today. But we do need to identify in those individuals who regain weight what might be the etiology of their weight gain. Certainly we have to rule out the anatomical etiologies first, and those would certainly go to a surgical or endoscopic intervention. But understanding the physiological things that happen, whether it's smoking cessation, pregnancy, menopause, even being put on a medication, may cause weight gain. And on top of that, we have the behavioral reasons, whether it's irregular eating behaviors, eating high caloric foods, not exercising, etc. And that's where the medical therapies may occur. So we certainly can understand that changes in the microenvironment can contribute to weight gain. Here's somebody who responded very well a year later and then had 47-pound weight gain in just a matter of 5 months. By doing a careful history, medication was identified that was likely the cause of that weight gain. Speaking of medications, I think it's important to understand that there are a lot of medications out there that can cause weight gain. And we should identify these medications and review someone's medication history when they present with weight regain. Certainly the psychotropic medications, antidepressants, and other psychotropic medications for bipolar disorder and other mental illnesses are notorious for causing weight gain. But we shouldn't overlook beta blockers, antihistamines, Depo-Provera, etc., as potential weight-promoting medications as well. Therefore, the strategies that we think about with our patients are really to try to tailor and individualize that therapy, specifically in the post-surgical intervention. Currently, post-surgical interventions aren't well studied, and the current studies using anti-obesity medications are listed in this table. There's only a few more that I didn't discuss here, but these are the main 5, 3 being retrospective, 1 prospective, and 1 a randomized control trial. If we look at the top 3, Schwartz, Bajecki, and Stanford, the study design varies. We do see the implementation of different anti-obesity medications. In the case of Schwartz, it was phentermine versus topiramate. But the use of the medication was restricted to 90 days. And it was several months, in fact, almost 3 years after the time of surgery where these anti-obesity medications were initiated. Interestingly, phentermine had a significantly greater weight loss versus phentermine and topiramate. Again, that was at 90 days. Certainly, several subjects were on these medications longer, but these weren't part of the retrospective study. Bajecki looked at liraglutide after surgery, and again, looking at individuals who regained about 15% or lost, I should say, less than 50% of their excess body weight loss. And she looked at, they looked at medications for only about 12 and a half weeks. But again, the timing after surgery was more than 5 years. Certainly the use ranged, and this was a small Brazilian study. And lastly, Stanford was the last retrospective study that looked at over 14 years of data, 300 people or more. And so there was a lot of heterogeneity in the design. Over 15 different medications were looked at that were used. And the use of these medications, the actual duration of the medications was not known. But in all the medications put together in one bucket, about 7.6 body weight loss was lost with the use of medications. And topiramate was the one most likely to cause weight loss. The ARD in the MIRA study, I'm going to describe in a minute. But first, I would just like to show the topiramate showed about a 10% body weight loss. Like the odds ratio was there. But again, the duration of its use is not known. The ARD study was an interesting study because it looked at both the pre-operative and the post-operative period of time with the use of the combination of phentermine and topiramate. This was a prospective, open-label study looking at about 13 completers on phentermine and topiramate combination, at least 3 months prior to surgery. And the surgery was a sleeve gastrectomy, and followed them for 2 years afterwards. So it was a pretty good study in terms of the duration. And you see the data here and the difference between the two groups. One with the intervention of phentermine and topiramate lost 22 kilograms more than the other group. When we look at these results in terms of total body weight loss, the sleeve gastrectomy group lost about 27% of body weight loss. When the phentermine and topiramate combination was added both preoperatively and postoperatively, we saw a 38% body weight loss. The Gravitas study was another interesting study, was really looking at the effect of liraglutide on a hemoglobin A1C. This was a UK study of 5 different hospitals. I think about 71 individuals were part of the study. They wanted to know what happens in individuals put on liraglutide in those individuals who have recurrent or persistent diabetes, and that's a hemoglobin A1C over 6.5. So the primary outcome was actually the hemoglobin A1C, which showed about a 1.22% hemoglobin A1C difference. Here on this this slide, we see the weight loss. And this is about a difference of 4.23 kilograms in about 26 weeks. So the study itself was taking people more than 1 year after surgery who have diabetes, and they only studied the drug for 26 weeks. The interesting responder waterfall graph we see here. Certainly those in the liraglutide group responded better than placebo. You can see that visually. When we look at the data, specifically, we see responders in the liraglutide group, about 46% lost more than 5% of their weight loss. 15% lost more than 10, and only 4% or 2 individuals lost more than 15% weight loss. Again, this is only after 26 weeks. So there's many questions that still remain when we're looking at both at these two types of responses to surgery. Certainly the definitions of a suboptimal response hasn't been well described. And even the definition of weight regain in this sense, King et al., as well as Laudy et al., have looked at this, and there's not clear data. Maybe just looking at the max percent weight loss and some definition related to that. But certainly that can interfere with having a strategy. The timing, we just looked at the pre and post-op period. There's been papers out that looked at 3 months after surgery or 6 months after surgery. My practice has always been looking for the plateau after the individual resets their set point, about 12 to 18 months after surgery before I start pharmacotherapy. But we really don't know when the optimal timing is. And lastly, we certainly don't know what the best combination is, with not only all the heterogeneity in response of surgery, but you couple that with the heterogeneity of responses of individual medications. Whether we go from a mechanistic standpoint and look at liraglutide and sleeve, which has been done, or an efficacy standpoint looking at Qsymia or even semaglutide, or maybe just addressing people's hunger after surgery, we really don't know what the best combination is. So strategies for using postoperative pharmacotherapy. There's 4 major points that we would just point out. First, we need to use this appropriately, and I think there's many different factors we could use, whether it's cost, efficacy, dual indications of the medication, or patient preference. We'll use these to select our medications. We should have close follow-up with individuals on medications and continue only in those people who respond. And a responder is someone who responds more than 5% of the body weight loss within 3 months of using the medication. But also be aware that we should use combinations. We should treat obesity seriously and appropriately. And if they're not responding to one, or they respond to one, but we still need more weight loss, thinking about a combination is something that we should do. The Endocrine Society put out in 2016 pharmacological guidelines, as we see here. And these are the medications. The anti-obesity medications that are FDA approved are listed. There's only 5. Lorcaserin was taken off the market several months ago. And we see medications that are very useful for weight loss, but are FDA indicated for another reason. Those for diabetes, migraines and seizures, depression, as well as addiction. And all of these medications have been used in people after surgery, at least by myself. If we walk through a little bit, I'll show you this table. And if we walk through these medications, these are the FDA approved medications, and they're mainly here for your reference. But if we go into them, phentermine is pretty well known to be the most commonly prescribed medication. It's inexpensive, it's the first choice. Certainly, it's an old medication, which really been wrongly labeled as an addictive medication, which it's not. And the fact that people have all these sorts of cardiovascular side effects, which they don't necessarily do. Again, starting this medication low can be very useful in having people lose weight. Topiramate is not an FDA-approved medication, but I put it in this graph because when in combination with phentermine, that is the combination which is the most effective FDA-approved medication to market. Topiramate is a seizure and migraine medication, can be used in bipolar, it's a mood stabilizer, also helpful in binge eating disorders. It can be very interesting to use this medication in people who talk about thinking about food all the time or have excessive carb cravings. I found this to be very effective. In addition, I think those individuals who are back taking and drinking a lot of soda or pop, this has an interesting negative taste that generally gets people off carbonated beverages pretty quick. Liraglutide, I think, is a pretty well-known medication. Again, an injectable medication, which may be one of the reasons why you would not choose this medication. It's indicated primarily for diabetes, but again, there's both the Victoza, which is the 1.8, specifically for diabetes, and then Saxenda, which is the 3.0 milligram dose pen, and that's specifically for obesity. Again, price is a big issue here that might lead us not choosing this medication. Naltrexone, bupropion, or Contrave, that's a combination that is very interesting because it works in the brain and is helpful for sort of these hedonistic eating behaviors. So excessive cravings beyond hunger. Certainly, they can be used individually. They can be used in the generic form for depression or addiction or people trying to quit smoking. Again, I think it's important to understand some of the psychiatric side effects, specifically suicidal ideations and those with bupropion. Orlistat has really fallen from favor. Again, a pancreatic lipase inhibitor, which basically blocks 30% of our fat, ingested fat. And that obviously can be fat that's healthy for us. And certainly we know that's not the key to weight loss, especially after surgery. Other non-FDA approved medications for obesity are listed here. Again, they're certainly indicated for other things. Semaglutide, which has shown great results in phase 3 trials, is the most effective anti-obesity medication out there. It's just really indicated for people who have diabetes and very expensive. But again, this is insurance specific. Zonisamide is like a cousin of topiramate. It's very helpful in people who have insomnia, I think. You have to watch out for sulfa allergies, so naproxen and Bactrim, et cetera, as side effects. And also be worried about any kind of new rash that forms after that medication. Metformin is an oldie again, but a goodie. I think it can be very effective for weight loss in people who do not have diabetes, and studies have shown long-term effects of about 2 to 6% body weight loss 6 years after being on medication, metformin. And we also know some science is pointing to its effect in increasing GDF-15 levels, which may be quite interesting down the road. But again, I think one of its most favorable indications, which isn't very well known, is its indication for people who are on atypical antipsychotic medications and have weight gain because of those medications. The SGLT2 inhibitors are also used for weight loss, though very mild effect. They're very good for people who have diabetes and in terms of reducing the cardiovascular risks. In general, if you look at most of the studies put together that I did in this slide, we see about 3 to 9% body weight loss at best on average for these medications. However, we certainly know that there's people who respond very well to these medications, and certainly we need to find those individuals because they have upwards of 20% of body weight loss with these medications. I think it's important to find the early responders. The next 2 slides show 2 studies looking at people who've responded well. These were drug trials that looked at people who responded, as you see here, after about 10 weeks or so. And regardless if they're on the drug or in the placebo group, that weight loss, initial weight loss after 10 weeks, 12 weeks, predicted a 52-week response. Similarly, Ken Fujioka did this study looking at liraglutide 3.0, finding that those who responded, regardless in the placebo or intervention group, after 16 weeks, losing more than 5% of their body weight loss, were able to maintain their weight after 1 year. So how do we choose our medications? What do we look at? Certainly looking at efficacy, but also maybe a double benefit. What I mean by double benefit is looking where the medication might be indicated already, and then, for example, someone who has depression, maybe using bupropion first because it might help the depression as well as the obesity. And again, I talk about metformin with the psychotropic medications, but you see some of the dual indications here. In terms of finding the responders, I use this brief figure of teaching, looking at the 3-month interval. Certainly after 1 month, we should look for side effects of a medication, but after 3 months, we should use the benchmark of a 3 to 5% body weight loss. And if the individual does reach that or exceeds that, we should continue the medication. These are the people who respond. These are the responders that we just looked at in the trials. And they're more likely to have weight loss continue. Those who do not respond are less likely to, so we should change the medication. Not stop all the medications, but change out, stop this specific one and move on to the next. If cost is a barrier, I think the 4 medications on the left-hand side are easy to start and affordable. We see that they're all can be used in combination with another drug, and you see some of the research behind that. Again, if a monotherapy is not working, we have to consider combination therapy. So an example is this 72-year-old woman who had a BMI of 52. She responded quite well, but she was upset of not responding more. I tried topiramate. She developed a kidney stone, and I didn't give up. I ended up using metformin, even though she didn't have diabetes. She responded very well, losing another 40 or so pounds and getting down to a BMI of 29. This was a wonderful thing. Also, maybe we should use medications prior to surgery like the ARD study did. This is an individual who responded very well to surgery, specifically before surgery, and that was because the individual was on zonisamide. And so when it went down to regaining weight after surgery, zonisamide was selected again and produced some weight loss. Pretty interesting. Lastly, I think we should understand and ask our patients a little bit more when we see them after surgery if they have weight regain, and specifically looking at eating behaviors. Here's a study that looked at medications specifically responding and addressing certain eating behaviors, whether it's around appetite, whether it's around satiety or cravings. Both liraglutide and the combination of bupropion and naltrexone were effective in addressing some of these common eating behaviors. Lastly, we should understand that maybe the medications won't do anything. And so here's a good example of somebody who had and responded pretty well to surgery, but still went through multiple trials of pharmacotherapy over several years, really not budging. And it wasn't really until their Hep C treatment that they actually lost a little bit more weight. And again, it may take time to make the right choice, but we have to treat obesity seriously. So in summary, we need to identify the individual's response, as that may help tailor the individualized treatment strategy. We should assess weight gain, understanding the anatomical, behavioral, and physiological, as well as biological potential contributions. We should define, or at least be aware of, the 2 different states. One, inadequate weight loss, where we should use combination therapies pretty quickly. And the second one, when individuals respond quite well, but then regain their weight. That might be a more stepwise approach. Again, I think medical therapies are the most appropriate initial treatment in those individuals who regain their weight after surgery. So for take-home points, for weight regain, optimize the lifestyle, remove, reduce, and substitute potential weight gain promoting medications, and consider adding an anti-obesity medication in combination, and specifically continuing that in responders. When we tailor anti-obesity medications, we should identify factors that may have an ability to narrow the selection of anti-obesity medications. We should always start with a low dose and continue if they achieve that benchmark of 5% weight loss after 3 months. If one doesn't work, we should try another. We should use these medications sequentially to find those responders. And again, if one monotherapy isn't working after surgery, we should consider combination therapy to not only enhance the efficacy, but to reduce the toxicity. Again, thank you very much for listening. My name is Scott Butsch.